Description. Yeah, so I can tell you right now from looking at the waiting room, it's about half survivors and half undergraduate students. So I think, you may get some interesting questions from students that you wouldn't expect from the patients and vice versa. So
I'm going to real quick here edit my last slide and just put in my email address so that people can contact me with questions. They probably should be able to figure that out pretty easily anyway.
Well, we like it to be something that you offer rather than the other way around of us telling people what your email is. So as long as you're offering it, that's cool.
Yeah, I'm just adding that at the, all right, I did.
Cool, very good. All right,
I took like a course once on doing these talks and stuff.
Yeah.
Recently, and they always say leave your email at the end, and I always forget to do it when I'm doing my slides.
Where was the course through?
I was the American Headache Society had a emerging leaders program, and I was selected to that. So they gave, as part of that award, they did like some speaker training.
Yeah.
Things like that.
Well, congratulations. That's a great award.
Thank you. Yeah.
Yeah, we've been doing that for our researchers, especially, trying to think of how do they present their work to a lay audience, and then also social media training. There's just so much of that you're going to be doing or involved in some sense, especially in science. How do you build your brand on social media? So those kind of trainings have worked out pretty well for us. So, if we run those again, if you're ever interested, you're welcome to join those.
Sure.
All right, I'm going to go ahead and get them started. Get them in. All right, welcome back, folks. We'll just wait till everybody gets in and gets set up with their audio, and then we will start. So if you're here, you hopefully are ready for NeuroNights. So this is Ohio State's wellness education series. And tonight we are going to have a presentation on post-traumatic headaches from one of our neurologists, Kevin Weber. And so before he begins, and before I turn it over to him for his presentation, I just want to kind of do a little bit of housekeeping with you. So this is a new month for us in February. So our topic this month is going to be post-traumatic headaches. There will be 3 sessions as usual. So we're going to have tonight's session with Dr. Weber. We'll have a session next week, same time, 6:30 on a Wednesday, with one of our physical therapists and our brain injury rehab team lead, Alicia Kempton. And so she's going to talk a little bit more about some of the things that you can do to manage headaches and find resources in the community, and sort of an add-on to what Dr. Weber is going to talk to us tonight about. And then we're going to do something that we've been talking about for a little while. We finally got it in order on the 3rd week of the month. So that would be February 16th. We're going to have a brain injury survivor talk to us a little bit about, their experience and some of the take-home messages that we as peers, as professionals, as students, this NeuroNights group, can take away and reflect on as well. So we're looking forward to that. We're going to be able to do that in February and March. So we have survivor talks the 3rd weeks in those months. But we will start with just today with Dr. Weber. So Dr. Weber, I'll have you introduce yourself and kick it off. All right.
Hi, everyone. I actually see some familiar faces in the crowd here, the Zoom crowd, even a patient or two. I am a neurologist here at Ohio State. I did most of my training here. I did undergrad, medical school, and residency here. So I've been in Columbus for quite a while. I did go away to Cleveland Clinic for fellowship and for headache, and I also did a little bit of concussion when I was there as well. Here at Ohio State, I do a lot of things. I run our headache division here, which is growing. I am our associate program director for the residency program, and I help with our fellowship as well, associate fellowship director. And for your purposes, I also have a sports concussion clinic that I run with Dr. Sass on Fridays. I see non-sports concussions too. I work with the TBI folks and PM&R and see a lot of their post-traumatic headaches in my headache clinic. So very, very familiar with this topic. It's a passion of mine, something that I've been interested in for a long time. So tonight I'll talk a little bit about post-traumatic headaches. I don't really have a lot of disclosures. I do have some grants from some of the drug companies that make headache or migraine products. I have several inspirations here. I worked with Dr. Seifert down at Norton Healthcare in Louisville. He's an expert in this area, a mentor of mine, Dr. Russman up at Cleveland Clinic. And of course, I want to thank all my other mentors at Cleveland Clinic and here at Ohio State. They've shaped who I am. Dr. Misu is another great one. I know you probably are all familiar with him. It's a legend in PM&R here at TBI here in the Columbus area. So some of the objectives tonight, we're going to talk about post-traumatic headache, the different populations that get them, which is really all populations are susceptible to this. Humans are really good at hitting their heads on things, getting into accidents. And we're going to talk about the different pharmacological treatments, and we're going to talk about post-traumatic headache and the difference between that and migraine and other primary headaches. So we're actually going to start with that last part first. So if you look at concussion and migraine, they're very related to each other. So personal or family history of migraine is observed in about 80% of patients with a symptomatic concussion. And why is there so much overlap there? Well, without getting into too much of the nitty-gritty details, there's thought that in migraine patients, there's a hyperexcitability of your brain, and that can lead to an increased risk of sustaining a concussion or at least symptoms from a concussion. We know that pre-existing migraine is associated with an increased risk of worsened and prolonged symptoms after a concussion. We think that a concussion may cause what's called peripheral activation of the trigeminal cervical complex. And what does that mean? That means that a trauma aggravates the pain generator in your brain, and that's in your brainstem. It works from the outside in to aggravate the pain generator in your brain. So those are just some thoughts as to why there's so much relationship between headaches and concussion, and in particular patients who have the disease migraine and concussion. Acute post-traumatic headache is the most common symptom after a minor head injury. About 94% of all athletes who get a sports-related concussion, for instance, have headache afterwards. So and I definitely have seen that in practice. Pretty much all of my concussion patients have headaches afterwards. It's very rare that they don't, at least in the immediate aftermath. Now, sometimes the headaches resolve and some of the other symptoms remain, but I have very, very few patients who, at least at the beginning, did not have concussions, or sorry, headaches, their concussions. So the definition is really, for acute post-traumatic headache, is having an injury and then getting the headache after, at least within 7 days of either the head injury itself or regaining consciousness. Persistent post-traumatic headache or chronic post-traumatic headache is just the same above criteria, but it lasts longer than 3 months. And those are just some arbitrary definitions that we use. But if you're reading notes or reading your doctor's note or seeing what your diagnosis is, those might be some terms that are thrown around. Populations who get headaches. So there's many very different populations. We have military members, we have athletes, we have accident and assault victims, and we have people who have workplace injuries. And for those reasons, we always ask about external factors that may impact recovery, like pending litigation, workers' compensation claims, and future plans in sports with athletes. We have to know what some of those things are going on in the background, just so we have an idea of external motivations or reasons why people could be either overplaying or downplaying their symptoms, depending on what external motivations and factors are going on at the time. So we like to ask, that's why you might get asked some of those questions. Other questions that you would expect to hear from your provider, or you should hear from your provider, get asked by your provider, are there any personal or family history of migraine? That's very important. We like to know that. We like to know a detailed previous concussion history if possible. Like, did you have headaches afterwards those times? How long did it take to recover? Were the headaches like these? We always like to know in medicine all the little minute details about your headaches, where they are in your head, how long they last, what the pain feels like, etc. And then we definitely want to know associated symptoms that you might have, like dizziness, nausea, vomiting, auras, which an aura, if you're not familiar with migraine, is typically a warning sign that some migraine patients get before they have a migraine attack, such as flashing lights or squiggly lines, weird colors in their vision. Sometimes people get even tingling on one side before they have a migraine attack. We also want to know if you have light or sound sensitivity and neck pain. We want to know what you're taking for your pain, both over-the-counter and prescribed medications. Any triggers that seem to set them off. Are you missing a lot of work or school? And then do they worsen with activity? So once we've determined that you have post-traumatic headache, the obvious question is, how do you treat these? Well, unfortunately, because of all those different populations of folks that I mentioned, it's challenging to recruit patients for these trials. They typically, in my experience with post-traumatic headache treatment trials, because I've been offered some of these, my headache center before, and they typically want to exclude anyone with any kind of legal or external motivation for this. So no one who's having any pending litigation, those are all people who are excluded. They don't want anyone who's on workers' compensation, or BWC. They basically want people who don't have any possible confounding factor to their recovery. And that's challenging to recruit for. It's really hard to recruit patients for these trials. So we don't have any randomized controlled trials right now, which is tough. Now, migraine is really easy. There's a lot more migraine patients than post-traumatic headache patients, and there's like an endless pool of patients to choose from. And so they don't typically have a problem recruiting. There are other problems with migraine trials, such as the lack of diversity in those trials, but that's for another day, another discussion. Standard of care is typically we treat the headache like the primary headache type it most resembles. Usually that's migraine. And sorry if you hear any children crying in the background. I am at home and I have two 16-month-old twins. So if you hear any crying in the background, just ignore them. So for migraine and for post-traumatic headaches, we kind of treat these very similarly in both the acute and the chronic management. And by that, and I'll get to that a little bit more in a minute, when we talk about both rescue treatment and preventative treatment. We talk about treating headaches. Rescue treatment is what you take when you have do when you have a severe attack, but it's not something that you necessarily take every day. Preventative treatment are interventions that we do to try to prevent the headaches from happening and lessen the frequency. So some people, their headaches are so bad that they need IV rescue treatment. We have this available at our infusion center, that there's similar combinations of medications that you would get if you wanted to break a severe migraine attacking cycle and you went to the emergency room. There have been some studies looking at those various combinations of medications. And again, these are not randomized controlled trials. These are mostly case series, but did show that some of those medications can be effective. The ones that I'm listing on here, I've listed their generic names, but the ones that the names you may be more familiar with are the brand names, such as Compazine, Toradol, Zofran, Reglan, are some of the brand names that have been studied in the past, and these have had some limited success with in case series with post-traumatic headache as well. And I do use these sometimes for my post-traumatic headache patients. Home rescue therapy, as the therapies again are similar than for what we use with migraine. Acetaminophen, which is Tylenol, NSAIDs, combination analgesics, and what that is like Excedrin, or which is Tylenol, caffeine, and aspirin all together in one pill. Triptans, those are migraine-specific medications. You may have heard some of their brand names, such as Imitrex or Maxol. Orgots, those are older medications, not used quite as much anymore, but we still do use them. Cafergot is the most famous one, probably. Anti-nausea medicines, and then there's some newer medications, which we'll talk about later, that are available for migraine, but we also use in post-traumatic headache. There are some clinical things that we keep in mind when we're treating these headaches. The main thing I think that's important is that we try to avoid what's called medication overuse, which means sometimes if you take too many rescue medications, or if you take them on too many days, you can have what's called rebound or medication overuse headaches, which is like a continuous low-grade headache that patients will get if they overuse or take too many rescue medications. And it's no one's fault. I mean, patients don't know that. It's not like they're addicts or anything like that. The natural inclination is if you have a headache or pain and you have a bottle of ibuprofen or a bottle of Excedrin or whatever next to you, that you take it. But we try to educate our patients that they should try to limit that as much as possible, ideally 10 days or a month or less. Sometimes in the management in the acute stage of post-traumatic headache, we'll use steroids, oral steroids, muscle relaxers, some other medications like depakote or valproic acid, and sometimes even those IV treatments I was talking about. For preventative treatments, again, pretty limited evidence for these, and we use a lot of migraine or tension type headache treatments for prevention for post-traumatic headaches as well. Amitriptyline is one that's an antidepressant used for, it helps, it's sedating, so we use it for sleep. There have been some studies that have shown benefit in post-traumatic headache. There can be side effects with this medication. People do not like weight gain. There can be dry mouth constipation. They're not necessarily safe for people who have irregular heartbeats. Valproic acid is another older medication. That's a seizure drug. Depakote is the brand name. Can't give that to women of childbearing age because it can be very toxic if a woman becomes pregnant. There can be other side effects such as hair loss, tremor, weight gain. So again, we have to be careful about who we give these medications to due to potential side effects. Topiramate or Topamax. This one's a very famous medication. It's a seizure drug again, very popular in headache, very effective, and has been shown to be helpful in traumatic brain injury, post-traumatic headaches. The problem with this one is that there can be some cognitive dysfunction and word finding difficulty. In my experience, patients who have suffered a concussion or traumatic brain injury have those issues anyway, and especially in the immediate aftermath after concussion. So for patients who are having a lot of fogginess, word finding difficulty, cognitive complaints, I stay away from this one typically. Other oral medications that we sometimes use, again, off-label. Really all treatments for post-traumatic headache are off-label. There's no FDA-approved treatment for these. Beta blockers, which is a blood pressure medication. Memantine, which is actually it's an anti-Alzheimer's medication, funny enough, but it works for migraine as well. Candesartan, which is a blood pressure medication. Nortriptyline, which is similar to the amitriptyline that I mentioned, and then venlafaxine, which is Effexor is the brand name, or its cousin Pristiq. We sometimes will use occipital nerve blocks and other interventions for post-traumatic headache. I use these a lot for patients who have occipital neuralgia, which is an irritation of those nerves in the back of your head. Oftentimes, those are irritated in concussion. We will do an injection with occipital nerve blocks, or an injection with anesthetic, and sometimes steroids in those spots that are labeled here on the diagram. There's a few studies and a lot of anecdotal evidence that physical therapy of the cervical spine or neck works well in post-traumatic headache, and I use that a lot. You're going to hear from Alicia next week, who is, one of the world's best physical therapists for concussion in my mind. And she has a lot of great colleagues here as well at the medical center. But our traumatic brain injury team here is unbelievable, by the way, and I'm sure those of you who have worked with them know that. I worked at Cleveland Clinic for a year. Everybody knows Cleveland Clinic's a great hospital, but they have nothing like the therapy team that we have here for concussion in particular, but even for other headaches as well. So they do a wonderful job. They're going to talk to you next week, her and Cheryl, who's our wonderful ocular therapist who works with traumatic brain injury. Other things, there's SPG, which just stands for your sphenopalatine ganglion block. That's a bundle of nerves behind your nose. Sometimes we will do those kinds of blocks for post-traumatic headache as well. Botox, which is monobotulinum toxin A. You may have heard of Botox. It's used for cosmetic reasons most famously, but it has a number of other medical purposes, including it's used in migraine. It was studied in a group of military members who had chronic post-traumatic headache. Most of them received the preempt protocol, which is the chronic migraine standard protocol. That's a series of 31 injections, and that is done all over your head and neck. It sounds very scary to get that many shots in a visit, but it takes me about 2 minutes to do it. In this study, about 64% felt better. They had a difficulty quantifying that. And then this was, again, a retrospective study, but at least there's some preliminary data that this can help. There's been some new treatments in migraine that potentially could be used in post-traumatic headache as well. I'm not going to go over all these in great detail today, but I just wanted to put these on your radar as some treatments you may hear about or read about in your support groups. There's transcranial magnetic stimulation, which is magnet stimulation on your head, and that is done used in other conditions like depression, migraine, and there was actually a small positive study in persistent post-traumatic headache a couple of years ago. Transcutaneous supraorbital neurostimulation, what does that mean? That's stimulating a nerve on your forehead. That's the Cephally device that you may have read about, and it's kind of like a TENS unit on your forehead. Non-invasive vagal nerve stimulation is a device that stimulates your vagal nerve in your neck. So you put it up against your neck and stimulate your vagal nerve. We'll talk about these new CGRP treatments, calcitonin gene-related peptide antibodies, in a minute here. Those are all over TV. You're going to see ads for those all over television, especially when the Olympics comes on here soon, next week. And then the serotonin agonist here. This is similar to the triptans. It's lasmiditan or Rayvow. That's an acute treatment for migraine, and it's similar to the triptans or like Imitrex and Maxalt rescue treatments for migraine that are already out, but these ones are safer in cardiac. This one's safer in cardiac patients. So
Kevin, can we take a quick?
You're going to see a lot of.
Kevin, can we take a quick break for a second?
Sure.
There was a question in the audience. Chuck, do you want to go ahead and ask your question? He's getting there. Give him a second. Maybe that'll help him out. Just a second.
Sure.
Okay, I'm gonna have Chuck type it out. Oh wait, hang on. Now here we go. Chuck, can you hear us? Be a challenge. All right, we'll see if Chuck can type out his question. Go ahead, Kevin. And once I have it, I'll interrupt you.
Yeah, I'm almost done. I don't think I only have a few slides left.
Okay.
So CGRP, that is basically it's a protein that circulates around your body. It's known as a cause of migraine. There have been some treatments designed to target this molecule, this protein, and block it and stop migraine. They're very, very popular drugs. They have a great, for the most part, low side effects. They're easy. Some of them are once a month shots. They even have some oral versions now. They have revolutionized migraine treatment. In the last 3 years, there's been 8 new migraine treatments, and 7 of them are targeting the CGRP pathway. There was an open label study done in 2020, which looked at this in post-traumatic headache and showed that it was beneficial, reducing on average about 3 days a month of migraine days. The problem was this was an open label study, which means that it wasn't compared against placebo, which is the gold standard in determining how effective a treatment is. If you looked at these medications in their clinical trials for migraine, they had fairly high placebo rates as well, although the rates with the real medication was significantly better than the placebo. So this is an area of further study. Again, like I said, these trials are challenging to recruit for, but continuing to study these medications in post-traumatic headache, which is exciting because they're great medications. They have low side effect profile, and they're in this case, this is a once a month injection. Erenumab is Aimovig. You may have seen some ads for that. Other similar ones are Emgality and Ajovy. Vyepti is an IV infusion. That one's a little less common because it's a little more expensive. And then there's some of the oral treatments which are used for either rescue or prevention are Ubrelvy and Nurtec out on the market now. And the newest one is Qulipta, and I actually saw an ad for that the other day. So all of these medications are either in the process of or going to be studied for post-traumatic headache, and the very limited early data seems to be that it helps similarly as it does for migraine. Behavioral treatments are great too, and we use those. We use cognitive behavioral therapy. There's been some mixed results in the literature. Biofeedback has been promising. Biofeedback is that's basically studying your body's response to certain stimuli and then trying to get you to cope with it. So like, for instance, if your heart rate goes up every time that you have pain, they use some strategies to help it so that your body doesn't have that response. There's been a positive study in acupuncture. We use some migraine treatments off-label, including nutraceuticals, like we like to call them, which is just natural vitamins and things that can help with headache, like magnesium, coenzyme Q10, and riboflavin, and those are over the counter. Riboflavin is also known as vitamin B2. So just some general pearls here at the end. We know that what we call headache lifestyle or headache hygiene. I don't like to use hygiene as much because it makes it sound like if you don't do those things that you stink. But headache lifestyle is the way I like to phrase it. And we counsel our patients on making things that are good for migraine are also good for post-traumatic headache. Migraine is a irritability of your brain, as I explained before. Many people are born with a susceptibility to develop migraine. There's usually a strong family history component to it. But it's an irritability of your brain. Basically, your brain is a finicky old lady or old man who is set in their ways and doesn't like changes in their routine. And think of your brain that way. And if you think about it, after having a concussion, your brain becomes that way too. So we counsel our patients to not do things to keep a routine. If you have caffeine, that's okay, but try not to fluctuate. Don't skip days. Try to have roughly the same amount every day. Stay hydrated. Your brain doesn't like being dehydrated. Eat regular meals. Don't skip meals. Your brain doesn't like being hungry. Exercising is important. Keep your brain in shape. Your brain doesn't like not exercising. Doesn't like being lazy. Sleep is really, really important. And if your provider isn't bringing this up, that's doing you a disservice, because it's really, really important in post-concussion recovery and in headache in general. It's one of the things that physicians and providers often overlook, but it's really, really important. Same with mood. That's really, really important too. Unfortunately, our mental health system in this country is not great, and people do not have the access that they need to mental health care resources. But we do our best with what we have, and mood management is really important in headache. If your mood is, we know that uncontrolled mood is associated with more headaches, and vice versa. If your headaches are uncontrolled, that makes your mood poor too. We talked a little bit about the medication overuse earlier in the talk, but that's something that's really important, to make sure you're not using too many rescue medications. And then, I talked about this a little bit midway through, but, a multidisciplinary approach in traumatic brain injury management and headache management is really important. We work with psychology, physical therapy, vestibular therapy, occupational, which is usually ocular therapy, and speech therapy for other concussion symptoms too. So having a team on your side and managing all these symptoms is really important. And we have a great team here, like I said. Feel very fortunate to be here. Certainly there aren't these resources available at every hospital in the country. I left my email here at the end, so if you have any questions, you can feel free to reach out to me. I'm very accessible. I try to answer quickly. That's your way to reach out if you have any questions that you don't think of to ask in our little session today. Or if you're listening to this on a recording and want to reach out with a question, I'm happy to answer and give you my best shot at it. So that's all. So I'll leave it open to questions if anybody has any.
Awesome. Thank you so much, Dr. Weber. So for folks, if you have questions, you can raise your hand and we can have you ask your question out loud. You're always welcome to type it in the chat, and I'm happy to read those out. We've got about a half an hour, so there's plenty of time to get your questions in. I will get us started real quick with just kind of a plug. Kevin, you mentioned, just managing mood and mental health after you probably in the context of both headaches and concussion separately and together. So next month, I just want to remind people that we are talking about mental health as well in the context of brain injury. So definitely come back to that. I'm sure that we'll find good reasons to talk about it from our conversations this month. And Kevin, if I can just start with probably an easy but maybe hard question. So you talked about a lot of medications, a lot of things that are, maybe newer therapies and kind of some lacking evidence out there. So maybe to start off, how much has this field changed in the last 10 years? For someone who may have gotten, a post-traumatic headache 10 years ago, would the care being offered at the time be significantly different than it is now?
Yes, because like I said, there's all these new treatments for migraine now. And because there's so much comorbidity and overlap there. And anyone who sees me and my team will notice how much I stretch to try to add the label of migraine to your diagnosis. And the reason I do that is a little bit sinister, but it's in my ongoing battle with insurance companies. Because if I just say you have chronic post-traumatic headache or acute post-traumatic headache, they say, well, there's no approved treatments for that, and there's no randomized controlled trials for that condition, so we're not going to pay for anything. We're not going to pay for any of these medications. So I really try to, when I see patients, try to tease out migraine symptoms in them. And you'll see that if some of you are on the call here are my patient and probably know that. It's because it's, in the headache world, we think that you can have more than one diagnosis. And we know that migraine and post-traumatic headache are so related to each other. And we want to try to get you the best treatments for you, and try our best to do well by you. I think that 10 years ago, there weren't that many treatments anyway, even for migraine. I mean, 10 years ago for migraine, we had the triptans, which are for the rescue, which were great, but there wasn't that many great options for prevention of migraine. It was all drugs that are used for other purposes. I mentioned several of those earlier in this talk. Amitriptyline is an antidepressant. Topamax and Depakote are seizure drugs, and there's blood pressure medications like propranolol and candesartan that are used. Those are blood pressure medications first, that have just so happened to be used for migraine. But the number of options in the last 10 years has really increased. And I think awareness of post-traumatic headache has as well. I'm sure you're aware that, the concussions in the sports world, I think, has really heightened TBI awareness in general over the last 10 years. Even if it's not sports related, it's heightened awareness of traumatic brain injury in general, and increased interest in the field. So that sports, that sports concussion interest in the media has heightened the awareness of TBI for all TBI survivors, which I think is a good thing.
All right. So next we'll have Deneen, you have a question.
Hi. First of all, before anything else, I just want to say thank you so much for doing this for us. So that's number one. Number two is I have had migraines my whole life, so I'm used to that. But since my TBI, I have them more often, and they used to always be hormonal, like every month, 1 or 2 a month at the same time. So now it's like there's a lot of neck pain going on with it. Now I saw that handout that we had about the injections in the back of your neck, and I just wanted to inquire about that because I wonder if that would help me, and what is it? I don't even understand what that is.
Well, there's a number of different injections in your neck, and you're welcome, by the way. I don't mind appearing at this at all. I work with KDAR quite a bit, so always happy to help out with outreach. But injections in the back of there's a number of different types of neck injections you can get. That occipital nerve block is more in the back of your head. It's a little bit into your neck, but that nerve comes out at the base of your skull and it innervates the back half of your head, and a little bit of your neck. There are other deeper injections that I don't do, but some of my colleagues do over at the Spine Center and in neurology, and it's like epidurals and set injections and things like that. And we do use those for patients with a lot of neck pain if we need to. cervical management in general, your neck management in general is a big part of what I do when I see all headache patients. I always assess that. And that's certainly part of the management of headaches. The neck plays a huge role in headaches for a lot of patients. It's not all. I mean, for instance, I have migraines myself, and my neck doesn't see, like I don't, that doesn't seem to be prominently involved with mine. I mean, yes, if I kink my neck or wake up the wrong way, that can trigger a migraine. But for some people, that's like the main driver of their headaches. Like, and that may be a big driver for you. Hormonal is certainly I mean, that's a very, very common trigger in women. With migraine is way more common in women. We know that women, unfortunately, typically suffer post-traumatic headaches more and for longer after a concussion. So, you know, the hormonal influence is certainly very common in migraine. But you know, like you kind of point out what on my last slide there. It's all about looking at the whole picture and the multiple different contributing factors that contribute to headache, rather than just, you know, one thing and trying, you know, medication. We look at everything.
All right.
Thank you.
Good
Thank
question,
you.
Janine. Next up, we'll have Grant.
Yes, I had a TBI 4 years ago. I was knocked unconscious and hit the right side of my head, causing a subdural hematoma on the left side. And I had to have craniotomy to repair the brain bleed. It's been a little difficult for me as far as speech and motor skills. But what my question is that my head bothers me more when the barometric pressure changes and, you know, when the weather changes. Is that a common thing for TBI patients to face?
For sure, and in migraine patients as well. You know, as a headache specialist today, about half my patients at least had migraines in the office. I had one this morning. Luckily, I was able to nip it in the bud before work, but with my rescue medication. But it's very, very common, and not just in TBI survivors, but also in migraine patients. And that again points to the overlap that I was talking about and the connection between the two. We don't know exactly why that is. There's a lot of different theories as to why the changes in barometric pressure causes migraine. But again, I think it goes back to that irritability of your brain and your sensitivity to environment. And the irritability of your brain. It doesn't like changes in the routine. It doesn't like changes in weather. Unfortunately, I'm guessing most of the people on this call are in Ohio, and there's not a whole lot we can do about the changes in weather here. But that's unfortunately one of the things that's really difficult to control. And I always tell my patients the way that they can is make sure that they have a good rescue plan for when the weather changes, and make sure that they have if they are having enough of headaches, that they have a good preventative treatment plan.
Is there any medication that would help that? I currently take trazodone every day and propanol every day. And I've asked about doing Botox, but I also have the opioids as a rescue, which I really don't want to take, but like today I had to take something. I just couldn't go
Right, and I
without it.
think you know, the opioids aren't necessarily, we don't love those, yes, but they're as long as, you know, the goal is to not take them every day, but if you're using them occasionally, that's okay. The other, I think just talking with your doctor about making sure that your rescue treatment is optimized. And then also, because we talked a lot about those today as well, and that your prevention is optimized as well as the best way. There's not like a specific medication for when the weather changes that I can tell you to take. I think it's just, you know, managing your headaches better in general is going to help you through these weather changes that we have. I mean, I think today is particular, this is a pretty big storm, as you all may know. And today, this one in particular, I think is a pretty heavy hitter, but ideally, if you get on good preventative treatment and have a good plan, every little weather system that comes through won't aggravate you.
Thank you.
All right. Next up, we'll have Sherry.
Thank you for the opportunity to ask a question. I had a low brain stem brain injury 8 years ago from a high-speed rear-end impact sitting still on a state highway. And I was sitting sideways in the car talking to my husband, so I did not have the front and back whiplash. It was side to side and was very, very injured on so many different levels and systems, and had a lot of treatment for, well, my last diagnosis was right before COVID started, through functional medicine at Cleveland Clinic, that I was stuck in fight or flight. And I did brain hoppers, DNRS brain rewiring program, and had great success in helping my brain function and getting me out of that kind of brain fog and low function that was caused by that. But what I've noticed is my function ability went up. And so I started to re-engage back in life, and I do a lot of social public speaking and managing groups of people with schedules, you know, like we're doing like a 2-hour program and things like that. And what I've found is from the executive brain function fatigue, because of using my executive function, that I get a headache that I feel like it's exactly like I had as a concussion headache, where before I had my brain injury, I had different kinds of headaches, but this feels like the exact same thing, like the plane, and just I feel like every part of my brain, like the synapses, hurt. So is that what you were talking about, the persistent post-traumatic brain injury headache? Is that what that is? Because I've been kind of concerned that I'm experiencing that same phenomena with a headache 8 years out. And it's been consistent, but now I have times after doing the brain rewiring where I don't have any headaches at all. And then
I think that's a great point. So I think that persistent headache is kind of a bad term because that implies that it's always there. And I see all the time patients who, that's why I usually use the term chronic, because I have plenty of patients who, you know, they have headaches that are clearly from their injury or got worse after their injury, but they're not always present every second of the day. Like sometimes they'll have periods or even days without a headache. They just have more headaches than before. And I think certainly that's what you have. Is that what you were asking?
yeah, I've gotten out my glasses, the blue glasses where I sit and look at a 40-watt light bulb with the blue to calm my brain down. And I have great success with just that quieting my brain. I just didn't know if there was something I needed to be concerned about, that this is something I will have for the rest of my life because of overstimulation. Because I also noticed that I just came through a period of having a lot of intense executive function for like weeks on end with a program that I was getting ready for. And then I started to have sound sensitivity because I know I had brain fatigue. So all those systems that were challenged just injured with the brain injury kind of became more, it got turned up. But do you think I should do anything to explore this more? Because I don't feel like it's interrupting my life, but I don't know if I should be concerned. And I would be interested in being in a study if you do one, if you want someone like me with a brain injury.
Yeah, I certainly, we don't have any studies right now for post-traumatic headache this minute, but we are exploring those types of studies, and we know that we have a nice population base here at Ohio State to recruit from. But I think, as a headache specialist and neurologist, with the headaches we worry about are ones that are new, like within the last several months, or significantly worse than before. If you've had a headache for a long time, then it's typically less concerning for us from the standpoint of, well, you're not dying, you don't have anything terrible going on. And I'm not dismissing your headache. And at that point, once we can turn off the worry about something serious, then we turn to, well, how is this affecting you? Like, is this something that's really bothering you that you need help with? Or is this something that you've learned to manage with and can cope with? And I think certainly coming to talk to us, or certainly if this is something that's concerning, or if you want to explore different treatment options, we certainly would be happy to talk to you about that. But yeah, I think usually in our world, in the doctor world in general, the first thing we worry about is what's deadly, life-threatening, something that can be potentially really disabling. And once that's ruled out, we take a deep breath and say, okay, well, obviously this is still concerning you or it's bothering you. So what can we do to help at this point once we've ruled out the bad things? But from what you're telling me is that you've had this for several years since your injury, and it's probably not something terrible, but at the same time, we just kind of got to go by you, and you know your body better than anyone as to how much it's bothering you and whether you want to seek out treatment for it.
I think the thing that concerned me is I've never read anywhere about head injuries and having the concussion headache, like a syndrome that would be long-term. You hear about people right after having a head trauma that they have the concussion headache, but I've never run across anything that's like, this could be a part of your life for the rest of your life because of the footprint that's left from your trauma. And it's to be anticipated as a possibility of just being what your world will be.
Yeah, I understand that. Unfortunately, we do see that quite a bit, where we see, particularly with patients who had headaches before the injury, that they can have worse headaches afterwards.
Okay, and I did.
And that can be persistent for months or years afterwards.
Okay,
it's like your new baseline.
Okay, great.
But that doesn't mean that it's not treatable. It just means that if you do nothing, that might be your new baseline.
Okay.
Does that make sense?
Yes. If I'm not overstimulated, it's pretty under control. So it's almost like going and working in your yard and cutting down a tree and stacking wood for the whole weekend. You're not going to feel so good. But if you have normal living, then it's like I overused my brain, and that's when I paid for it. Thank you for your time.
No problem.
That's a great question, Sherry. Thank you. If we have time for all the questions, we will get to them, but I at least want to get to Caitlin's question here. Go ahead, Caitlin.
Hi, I'm pretty exhausted, so I'm just hoping that I make some sense. I have been noticing since school started that you're my doctor, full disclosure. So I'm on the Topamax and I do the Ubrelvy. And then, so I don't take any other headache stuff other than those. So, and I try not to take anything else like the Ubrelvy too often. So I have had to take it a couple times over the last, I'd say 2 weeks. I've been getting pretty exhausted with all with all the PT appointments and different doctors and everything going on. So my cognitive exhaustion has been, I would say, going excessive over the last like 2 weeks. So I guess I'm wondering about that's been causing me extra headaches. So I'm wondering if when those headaches occur, would that be something that could be helped with the shots at the base of the head? I do have Valium, but I don't want to be taking it all the time. I already just don't like to take it all the time.
Well, for one thing to talk about your Ubrelvy, I didn't get into this too much, but that for everyone's education is one of the new CGRP treatments. And that's an oral medication, and that's for rescue of migraine. And that, interestingly, does not cause the rebound headaches that I talked about.
Oh, I guess I didn't know that, or I
So you
didn't
could
remember.
probably take that more often if you needed it,
Okay,
especially if you.
I'll write that down.
The
'cause I probably
limitation
forgot.
with that is the amount that the insurance company will give you, or they'll let you have per month. Usually,
Okay.
sometimes it's for that one, it's 10 or 16 per month. But if you get 16, then you could take it almost every other day if you wanted to.
Ooh.
But that's the kind of the minor details. I don't want to get into that too much, but that's one of the newer medications, the migraine medications. That's another benefit of those medications, is that they don't cause the rebound headache that some of the older medications do if you take them too often. I'd have to go back and look and see what in your notes, like what your exam looked like and stuff, as far as the shots in the back of your head. But
We can
certainly
talk about
we
that
use
later.
those we use those as an adjunct, and it's an option to any of my patients that have sore or tender back of their head, in that region of the occipital nerve. We can use those as a sort of a cycle breaker if you're having a bad cycle of headaches. I'll use those. They're not permanent. They don't last forever, but they can last for weeks or months and provide some temporary relief for my patients who are having bad cycles. And I do those in the office.
Okay, I guess that would be an option because I can't really touch the back of my head or lay on it. That's a whole part of the neck PT thing. too.
Yeah, well,
Okay.
shoot me a message on
Okay.
my chart and we can discuss further. And that way I'll have your chart in front of me and I can
Okay, awesome. Thank
I
you.
can think about it and get back to you on that.
Thank you.
I'm muted. All right, and so I think we have time for one more question. Janine, I see you have your hand back up, so go for it.
I just wanted to know what the name of that nerve is in the back of your neck. What is that
Occipital,
called?
I'll call it your occipital nerve.
Occipital nerve.
Yes.
And then what was she talking about with the glasses and the light? Like putting certain glasses on and then looking at the light? What's that all about?
Well, there are some glasses that you can get online or from your eye doctor that are tinted, that filter out certain parts of the light spectrum that can aggravate headaches.
Oh, okay. Thank you.
TheraSpecs is one of those. If you look online, but there's numerous different brands online for those that can sometimes help my patients with headaches who have, it filters out the blue end of the light spectrum.
Okay, thank you.
Good question, Janine. So with that, I don't have any other questions in the chat. So Kevin, I guess, one of the things that I just want to maybe think about as a takeaway message here is it was really surprising to me just how much there was overlap between headache and concussion, sort of in their separate spaces. One of the things that I know about brain injury is that it's so complicated and personalized. And it sounds like headache is the same way. So, if you're struggling with these things, I kind of think about two problems. One is, do you have to treat this on a case-by-case basis? Is it so personal that you really can't think about, general approaches? And then the second part of that is, what does that mean for barriers? You mentioned kind of getting insurance to cover medications, or maybe even getting diagnosis or getting access to a specialist. How should we just kind of prepare ourselves to navigate all of this?
Well, yeah, it is very personalized. And unfortunately, the access is hard for a number of reasons. If you're in this group, you probably are familiar with Ohio State, and we are pretty good when it comes, but there are patients in a lot of areas that have very little access to neurologists or particularly headache specialists. We have, it does take a while at times to get in to see me, but we are really working on that hard, and I'm trying to train as many young pups as I can to follow in my footsteps and do the same thing I do, but that takes time. But honestly, the insurance is a humongous barrier, and I don't know if we're going to be able to do anything about that anytime soon until we have a more uniform healthcare system, or at least a formulary to use. But I think if you find a good doctor, they should be willing to go to bat for you, particularly with the insurance companies. And I think that that's really important, because a lot of these treatments, as I mentioned, are for migraine, but they also can be used for post-traumatic headache, and with some success. So, I think the biggest takeaway would be an advocate with yourself. If you feel like your headaches aren't, or advocate for yourself, if you feel like your headaches aren't being managed, ask for a referral to us. It may take some time to get in, but we're working on that. And we're certainly happy to go over all of your options, because it is very individualized. Like, some people don't have any neck issues at all, and some people, that's a huge driver for their headaches. Some people, their mood's well controlled and they don't need that addressed very much. Some people, their sleep is great and they don't need that addressed. So it really varies based on person to person, and even what treatments will work for a certain person versus another.
Okay. All right. Well, folks, if you have any other questions for Dr. Weber, he had put his email out there, so definitely get in touch. I think this was a really great session, Dr. Weber. Thank you so much for taking the time to do this and answering those questions. Thanks for everybody for asking good questions and sharing, your experiences. So with that, we will be back next week. We have Cheryl and Alicia that are going to come back and talk to you a little bit more about some of the other types of approaches that we can try, or some of the resources that are available to you. And so definitely stop by for that. Otherwise, have a great rest of your night and be well. So thanks again, Dr. Weber.
Nice to see all of you.
Take care, everybody.